It's the 15th of March, 2019, and this is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. And this week in the news, a change in blockbuster drug sales, higher dropout rates on TNF inhibitors. Is that possible, and in what disease? And where's that DEXA you owe me? Let's start with that report. Almost 3,000 patients in a single center who were older, over the age of 50, went to the ER and were diagnosed with a vertebral fracture. And these were new vertebral fractures. And again, this is a study that was done between 2009, 2014. And the shocking thing is, for this large number of people who went to the ER, found to have a vertebral fracture, how they were treated subsequently is sort of shocking. Actually, the data is like 98% of people did not have a DEXA in the 2 years prior, so maybe they missed it, maybe they weren't watching for it. Again, they're over the age of 50. I think the mean age was over 60. And also in the year after the index vertebral fracture, they did not have a DEXA scan ordered. More importantly, only 7% actually went on to receive anti-resorptive therapy, 5% in the first year, 2% in the second year. And in the next 2 years, almost 40% of these people went on to have another fracture. This should be a knee-jerk reaction. I just saw a patient with this the other day. In this case, it was a metatarsal fracture in someone who's a postmenopausal woman. Happened 6 months ago. No bone density, no osteoporosis assessment, no treatment for osteoporosis. So this is a large deficit. I don't know why this happens. We as rheumatologists need to spread the word. A list came out this week of the top selling drugs of 2018 worldwide. At the top of the list is AbbVie's Humira with $19.9 billion in worldwide sales. There are other drugs that we use in our specialty. Number 6 on the list was rituximab or Rituxan at $6.9 billion, and number 10 on the list was Stelara or ustekinumab at $5.2 billion. Noticeably absent are the other two TNF inhibitors. Enbrel and Remicade have fallen off the list. The times they are changing. There's more, and I think that most of those changes and those drugs falling off the list have to do with worldwide use of biosimilars, not necessarily happening here in the United States. If we looked at top 10 selling drugs in the United States, I'm sure those would still be on the list, at least Enbrel would. But times they are changing, partly biosimilar, partly the use of these drugs is being challenged in other disciplines, especially psoriasis and psoriatic arthritis, by other agents, IL-12, 23 inhibitors, IL-17 inhibitors. Again, times they are changing. An interesting study looked at the association of progressive skin fibrosis in scleroderma patients and what happens to lung function. This is over 1,000 patients in the U-STAR cohort, and they define progression of their skin disease as greater than 5 modified Rodnan skin units, a change in 1 year. So they call that a rapid progression benchmark. And they looked at those people, and those people were more likely to have significant decline in lung function and all-cause mortality in that follow-up period. That's and we've already known that, patients who you worry about are those who have rapidly changing skin. That's always been taught. Here's another measure of that says the same thing. They didn't say give you other measures that would also have been correlated with rapidly declining lung function and/or all-cause mortality. An interesting study comes from the Osteoarthritis Initiative that shows that if you can lose weight, and they defined it as greater than 5% of your baseline BMI in obese or overweight patients, they looked at them over an 8-year period, and they found that the patients who lost weight by diet or diet and exercise had a significant decline in knee cartilage loss over this 8-year period. This wasn't seen in the individuals who lost weight by exercise alone. Kind of interesting there. Maybe it has to do with muscle mass in those people. I'm not really sure. But this is sort of encouraging data for you who are advising your patients. Weight loss is the way to treat osteoarthritis. That may be the most chondroprotective disease modifying measure one can employ in someone with osteoarthritis of the knee. The COBRA data, as you remember, is a study back from, I think it was the early 90s, which looked at early RA patients who were treated either with sulfasalazine or the combination sulfasalazine and high-dose prednisolone weaned down over a 6-month period. What they showed in that 23-year follow-up of those patients was they had basically a long-term survival to that of the general population, suggesting that early aggressive therapy has a survival benefit in patients with rheumatoid arthritis. More interesting data comes from the Corona Registry, where they looked at chronic opioid use in their RA cohort. They showed that it doubled between the years of 2002 to 2015 from 7.4 to almost 17%. The biggest predictors of chronic use of opioids was severe pain, not surprisingly, also antidepressant use, high disease activity, and high disability. It's the antidepressant use and the high disability that worries me. Maybe that's where some of the inappropriate use of opioids might be happening these days. It's something we need to worry about. We certainly know patients with depression, fibromyalgia and whatnot, use of opioids in that population is not wise. So there's an interesting study that came out this week also from Atul Deodar and his colleagues, looking at persistence on TNF inhibitors in patients with ankylosing spondylitis. So they took a claims database cohort. They identified over 1,000 patients, 1,372 ankylosing spondylitis patients between 2009 and 2013, and looked at a 2-year window from the time they started on their TNF inhibitor to the time that they stopped or whether they continued. The sad and bad news in the study is at 2 years, only 1/3 of patients were still taking the TNF inhibitor that they started with. 26% switched to another TNF inhibitor. That seems reasonable. So that means at 2 years, 50% are on a TNF inhibitor. However, 41% stopped the TNF inhibitor and did not restart it. That's problematic. The idea here, of course, with aggressive therapy in this cohort would be not only to improve signs and symptoms and function and pain, but also to improve long-term outcomes, including radiographic outcomes, damage, fusion, etc. Not going to be a change if they're not on persistent therapy. So is this because of the nature of ankylosing spondylitis patients being mostly male, maybe more non-compliant? Again, they didn't look at it because it's claims data that they looked at, but I think it's worrisome data. Again, the dropout rate on TNF inhibitors in rheumatoid arthritis tends to be about 10% a year or 50% at 5 years. This is at 2 years where you wouldn't expect to see more than a dropout of 30, at the most 40%, but really about 30%. They have 67% dropout at the end of 2 years. That's not good. That's actually a 60% because it's only 41% stopped. So anyway, but the bottom line is the numbers aren't really encouraging at all. EULAR came out with guidelines for the management of juvenile localized scleroderma, patients with morphea or linear scleroderma. We had a number of guidelines out this week, Brazilian guidelines for myopathies, the Swedish guidelines for giant cell arteritis. You could look at those. I chose just to highlight the juvenile localized scleroderma, where they say that when these patients are identified, they need to be referred to a pediatric rheumatologist. That there's a more liberal recommendation regarding use of imaging, either ultrasound of lesions and or MRI of the musculoskeletal system, and then if you have lesions of the head and face, especially the coupe de sabre lesion, that you need to do MRIs of the brain. But if it involves other parts of the face, ENT and ophthalmological recommendations and dental recommendations are also recommended. The mainstay of therapy is the early use of steroids if they're in the early inflammatory phase, but then everybody should be put on methotrexate. At the same time, they're put on steroids or put on methotrexate, and if not methotrexate, it looks like the second preferred drug there is mycophenolate, where they're seeing good outcomes with regard to the skin lesions over time. Lastly, tramadol was in the news this week. JAMA report showing that tramadol use may be associated with increased mortality. And this is in osteoarthritis patients, and 89,000 patients with osteoarthritis were either given initial first-time use of tramadol, and they compared that to several different nonsteroidals, about 40,000, and even a cohort with codeine. They showed that compared to nonsteroidal use, tramadol use was associated with a hazard ratio of 1.71 to 2.04 increased risk of mortality. Now, is that real, or is this confounded by indication? Turns out when you compare tramadol to codeine users, there was no difference in the overall mortality rates, but then is that higher too? I think this is sort of a big question mark. It needs to be repeated and studied in a different manner, but it's worrisome. And I think that maybe the take-home message here isn't that tramadol causes death, but that patients with osteoarthritis that require narcotic therapies or more aggressive therapies are in a different class as far as risk and ultimate outcomes. And there probably needs to be a better algorithm for managing such patients, one that we can all agree on. That's it for this week. Go to the website to look at these links and more. Be sure to check out RheumNow.live. Our big meeting is next week. You can register online and view it free from home, or you can come to Fort Worth and join in the fun. We'll see you next week.